How was the feeling amongst embryologists hearing that news of what occurred in labs around the world when things get mixed up?
It's a shock. Just hearing what could happen was scary enough for us. You just can't let it happen.
There's other technology as well of a more AI developmental nature.
Yeah.
What's your perspective on that?
I think at the moment we're using it for good. Where it goes from here, I'm not sure. But we're pretty protective of our embryos, so I don't think we'll let AI take over anytime soon.
Agreed. Alex, welcome to Knocked Up.
Thank you for having me.
It's wonderful to have you back on the podcast for the second time.
I know, it's been
a few years.
Yes.
It has. Alex, embryologists are often the unsung heroes in IVF.
Yes.
And people never get to meet you, but you do play such a huge role in their journey.
Yes.
Can you start by telling us what an embryologist does and also what brought you to this career pathway?
Yeah, so we are often the behind the scenes of the IVF process. We are there from the moment the eggs are collected up until the moment that the embryo is transferred. So we're there growing the embryos, looking after them while they're developing, while they've been frozen for many years. So yeah, we're there sort of right through the process. The reason I got into this role was, I think, just the magic behind like how an embryo or how a baby is created. I grew up with my mum being a midwife. Like I've always known sort of what happens once the baby's born. And when I started science at uni and seeing those cells divide under the microscope, I was just fascinated that like that was how that process started and that we could actually play a role in that. So yeah, I think that's kind of how I developed that passion for going into that role.
And it's not always a straightforward path to become an embryologist. Sometimes it's in some ways an apprenticeship of sorts to become a senior embryologist with a lot of skills to acquire along the way. What was your journey like?
I finished uni with a Master's of Embryology, which is sort of one of the higher qualifications you can get, but also what you need now almost, because it is a growing field. But then once you start your job, you really are an apprentice, like learning, you know, from the most basic procedures like creating a dish with the fluid in it that the embryos grow in and learning all about that right up until the point where you're biopsying cells out of an embryo to send away for genetic testing. So there's such a massive like range of skills that are needed and knowledge that's needed to do what we do.
It's kind of like being a microsurgeon when you do an embryo biopsy.
It is, yeah. It's pretty amazing. Like you can't even see what you're doing with your naked eye. So the fact that you need to look down the microscope to be able to like pull 5 cells out of an embryo is pretty amazing.
Were you nervous when you first learnt how to do that?
Very, yeah. Yeah, seeing my colleagues be able to do it, you know, in 5 minutes is, you just think it's going to be so easy. And then you sit in the microscope chair and try and push a needle inside an embryo and it's terrifying. But we have really like stringent and strict training protocols. So by the time you even, you know, touch a human embryo, you're so confident and competent. So yeah, it's needed.
Yeah, absolutely. Alex, in the media recently, there's been, I think, a lot of worry engendered in the public because of some scandals with embryo identification going wrong in certain situations. I wonder if you could tell our listeners the kind of things that we do as professionals in the lab to prevent errors happening with identification in IVF.
I think the first part is just knowing in your mind how important it is. I think not being complacent and just having that mindset that this is someone's potential baby and each of these embryos is a potential person. So like going in with that mindset is so important. We have set up double witnessing, so 2 people check most of our procedures, But then on top of that, we have electronic witnessing as well. So every dish, every tube is labelled with a barcode or an RFID tag, and you physically can't bring two different patients into the one workspace without it alarming. So there's technically 3 people involved in all our procedures to make sure that just that one patient's material is in the workspace at all times.
Yeah, I know that's so important also from a clinical perspective, and for some steps along the way that double identification is with a scientist and a doctor.
Yeah.
Such as, for example, at egg retrieval, when we check the patient's details, the patient's awake in our setting, so they are also an observer of that check.
Yeah.
And then we check the dishes together, and any tubes that eggs are going to go in get checked together, so that that's all very safe. But I think sometimes when stories come out in the media, understandably, people can really worry and not necessarily trust in the process.
Yeah.
As embryologists, I mean, I know as doctors, when I heard about those stories, it was pretty shocking to me. But how was the feeling amongst embryologists hearing that news of what occurred in labs around the world when things get mixed up?
It's a shock. It definitely shook us all as well. I think just hearing what could happen was scary enough for us. So even though we have really strict processes, it almost made us add an extra layer to what we already do, because you just can't let it happen. So we've added a few extra layers to our identification processes just to be extra sure. But it's devastating. So you just can't let it happen.
What's your favourite thing about being an embryologist?
I personally love the patient contact. So I think, I love creating embryos and doing all those laboratory procedures, but I think being able to speak with the patients before they come in for their egg collections or at their transfers and seeing what we do kind of means something to them is like the most important to me. And also being able to give them phone call updates, reassure them or counsel them when they're sad about an outcome. It just kind of puts everything into perspective for why we're doing it.
And sometimes those phone calls can be really emotional and really challenging, especially when something hasn't gone right. Like, for example, if an embryo hasn't warmed successfully. What training have you had, and I guess what experience has guided you in making those phone calls, both from a patient perspective but also from a personal perspective, because it is very difficult to give bad news?
Yeah. It's sort of something that you just sort of learn on the job and watch your colleagues when they make phone calls. When we first start out, no one wants to make the bad phone calls. You kind of dial the patient's phone number in, just dreading them answering the phone. But I think as you get more experienced, you realise that they just need that information regardless. And it has to come out, and you just have to deliver it in the best way that you can and be there to answer questions and support them. But at the end of the day, they need to know, their outcome. But we've been supported by our counselling department a bit to be able to give us some tips on nice ways to deliver bad news.
And have you felt that that's noticeably helped from the patient experience?
Yeah, I think so. Just sort of small ways like, being careful with the tone that you use when you are making the phone call or certain words to avoid. Yeah, it's definitely helped sort of our confidence making the call, but also hopefully helped the patient's experience as well, not to feel like they can't sort of ask questions back or, yeah.
Yeah, to give them a bit more power in a very disempowering situation.
Yeah.
I've always found in IVF, when things don't go exactly to plan, it can still be actually very helpful diagnostically to know what happened in the lab. And quite often in complex cases, I'll have a discussion with an embryologist to say, well, is there anything we can do differently in the future from a science point of view to try and get a better outcome for our patients? Can you tell me a bit about the advanced scientific techniques that we have available to us to try and help get better outcomes in the lab?
There's a few different options, and it really depends on what their outcome was to work out which angle we're going to take for next time. We've got the egg and the sperm, and each of them have their own reasons for why an embryo might not develop. So if we look at the eggs on the day, and when we have a look at them down the microscope, they are potentially oddly shaped or have some fragments inside them. We can feed that back to the doctor and let them know that the eggs were a bit irregular in shape, and that could be an indication for an egg quality factor. If we look at the sperm on the day and the motility is low, so how many are swimming, or the concentration is really low, that could be an indicator that there's a sperm factor involved. But it really takes up until the embryo is developing to work out, if there's something that's not going right. Depending on how the embryo development goes, whether it sort of stops developing after the first couple of days or whether it goes through till day 5 but then is a poor quality embryo, that sort of gives us a bit more information to use. So when we look at future cycles, there's a couple of different things that we can try depending on if we think it was the egg or the sperm that caused the poor outcome. And they're all a little bit sort of trial and error in a way, but there are some sperm selection tools that we can use where we put the sperm on a really high-powered microscope to try and get a really good image of the sperm head. That's where the DNA is stored. So the aim is to try and choose the best sperm with the best DNA, which is tricky, but it gives you a slightly better chance. So we can do that. We can also put the eggs in a special solution with calcium to try and promote their activation and that final stage of maturity for the egg. Then there's a few different devices that we can use to process the sperm in to try and be a bit more gentle, try not damage the DNA.
And there's other technology as well that we're, I guess, implementing in our generation that past generations haven't had access to in IVF of a more AI developmental nature.
Yeah.
Some things that we're already using and other technologies that we're thinking about using for the future. What's your perspective on that?
I think at the moment we're using it for good. What we're currently doing is putting all our embryo footage through artificial intelligence, and it's giving an embryo a score. And that score is really helpful to us in selecting or triaging embryos. So we can look at an embryo and give it a grade, and that's our own embryologist grade. But if we have 2 embryos that we've given the same grade to, then we find the AI score really useful at differentiating which embryo the AI thinks is better. So when we're transferring one of those embryos, we're transferring the best embryo into the patient that but also AI thinks is going to have the most chance at pregnancy. So it's definitely helpful for us at the moment. Where it goes from here, I'm not sure, but we're pretty protective of our embryos, so I don't think we'll let AI take over anytime soon.
Yeah, agreed. We talked about AI tools in IVF, but in context of everything that we do to assess embryos, it's still really a later tier overlay, isn't it? It's not a replacement of an embryologist.
Correct, yeah. So ultimately we're assessing the embryos, we're grading them on, what we think is the best looking embryo, and we're having multiple people check that sometimes as well. So it's often a bit of a group approach, but we do have that AI tool to support us if we need it and help us differentiate between 2 really, really nice embryos. So even though we're using that human approach to select the best embryo, if we can just have that tiny little bit extra support, we'll absolutely take it. the goal is to provide that patient with the best possible outcome.
Yeah, and just for our listeners, how that AI tool was developed was actually looking at a whole lot of embryos through the EmbryoScope incubator and then analysing which ones made babies and then educating the tool to better pick which ones were going to make a baby. So the embryologists, I think, still do an amazing, amazing job, and it's just about taking success rates to the next level based on the embryos we have when we're planning for a fresh embryo transfer. So that means when we're putting back an embryo without it first being frozen and warmed, and we have to choose just one. A lot of patients learn a lot these days because there's a lot of information online that's very accessible, and sometimes patients get very interested in embryo grading and can be quite invested in that. Can you tell me about the Gardner grading scale that we use to grade embryos, what it means, and then we can have a chat a little bit about whether, it really makes a massive difference.
So the Gardner grading system that we use is really helpful at being able to sort of differentiate between what an embryo looks like to us without having images in front. It goes from 1 to 6, and 1 is sort of a smaller sized embryo and 6 is a fully hatched embryo. And then there's 2 letters afterwards, A, B or C, and each of those refer to the quality of the cells inside the embryo. The first one being the inner cell mass, which is what becomes the baby, and the second one being the trophectoderm, which is the ring of cells that are going to become the placenta and the sac and supporting tissue. We give every embryo that sort of gets to that blastocyst stage a 1 to 6 score, and it really ranges from what is a poor embryo to what is a really good embryo. It's sort of important to know that that's what they look like on the outside. It doesn't necessarily mean what's going on the inside of the embryo with the genetics, the DNA. It's a bit of a tool that we can use to work out which embryo we should be transferring, freezing, biopsying, all those things. We do have a threshold for freezing, biopsying, transferring embryos. So anything from a B and above, we will transfer or freeze. C grade embryos, we do consider too poor, so we won't freeze or biopsy or transfer them. But it's definitely helpful for us to be able to triage embryos. Yeah.
And that can be a little bit controversial in some settings. I've seen talks given where clinics have looked at poor grade embryos and the fact that occasionally some of them after transfer have been able to make a baby. Do you have any perspective on that?
There's probably a chance. There's probably always a chance. It really depends on the patient's. If there's, one egg, it's fertilized, it gets to the day 5 stage, then that would be a discussion that we'd have with the doctor, see if they want to transfer it. But if a patient also has, 5 or 10 embryos, you could also argue that that could be giving the patient false hope to be freezing a C-grade embryo and having that frozen and in storage for years, thinking that it could be a potential baby when it won't. So I can see both sides of it, but when you're sort of creating embryos, you want to have a good embryo transferred.
It's true. It's a lot for a patient to go through the process of preparing for an embryo transfer only to be disappointed with the outcome. And also important to note that C-grade embryos, because they do have very poor cell layers, are very vulnerable to freeze injuries. So if it's not transferred immediately, they might be very damaged on warming.
Yes.
Women's Health Melbourne is an innovative holistic fertility and women's health practice. We are world leaders in IVF and egg freezing and provide our patients with every opportunity to achieve their goals. Our hand-picked expert team provides the ultimate care experience for our patients. Reach us at womenshealthmelbourne.com.au and follow us at Women's Health Melbourne and at Dr. Raelia Lew.
There is a perspective that everything we do to preserve embryos and even to test them from their perspective as an embryo is somewhat traumatic.
I wouldn't say that there is much of a risk these days. Yeah. Our freezing, our warming protocols are so robust that we have survival rates of over 95%. That's also why we do make sure that we're freezing good quality embryos, because we want to be confident that they're going to survive the freezing process and the warming process so that they're suitable to transfer. But we're always checking our survival rates per scientist for freezing and warming, making sure everyone's statistics are above that threshold. And we're constantly reviewing our protocols, the solutions that we're using. So we're pretty confident that when we freeze an embryo, it's going to survive the warm. Of course, there's always that 1 in 10 chance that it doesn't, but we go in pretty confident that it will survive. So if a patient has multiple embryos, I'd be happy with freezing them. Yeah.
And that's been a real revolution in IVF from a safety perspective, because in years past when we were nervous about freezing embryos, we were more likely to take a risk by transferring an embryo in a patient where conditions were not ideal, or potentially even when there was a risk of hyperstimulation syndrome, which is one of the medical concerns in IVF where patients could get very unwell. So the fact that we have such confidence in freezing really allows us a lot of flexibility.
Yeah.
And we're doing a lot of transfers of frozen embryos in natural cycles these days, and that allows patients to have a much gentler experience with a lot fewer medications. But it's also safer for babies, going back to that other side, kind of your mum's side, the midwifery, delivery, the goal of IVF is to have a healthy child. So.
Yes.
In terms of fertilisation, sometimes patients worry when they read IVF consent forms that ICSI, which is when we inject sperm into an egg, has had some associations clinically with some epigenetic, which means not imprinted in the genome, but changes in the genetics of a cell outside of the coding DNA that can cause some rare medical conditions. Do you have any feelings about that from a lab perspective?
From a lab perspective, the ICSI procedure of injecting a sperm into an egg is very non-invasive these days. So compared to natural IVF insemination, where you just leave the sperm and the eggs overnight together, we are making sure that ICSI procedure is as sort of quick, seamless as possible. So when we're doing the physical procedure of injecting a sperm into the egg, we're making sure that the egg isn't in that dish for too long. We're confident with our sperm selection choice. So when we look at the sperm swimming in the dish, we're able to pick a good one really quickly. And part of our training is that we inject that egg smoothly and confidently, and it's over with in a couple of minutes, and it's back into the incubator in its safe, cozy environment. So in terms of the procedure itself, I would like to think it's pretty non-invasive. There's always a small chance that eggs won't like it and they might degenerate if they're a bit more fragile. But at this stage, if there's a poor sperm sort of case, it is our only option, because the chance of fertilization with normal insemination would probably be too poor. But the ICSI training that we do, the position of the egg that we have when we are injecting it is to make sure that we're avoiding the spindles that hold on to the DNA, so that when that sperm does enter the egg, the inside of the egg isn't really touched too much. It's sort of as minimal as possible.
I think when we talk about ICSI and outcomes historically, when we look at 40 plus years of IVF, it's quite possible from what you're saying that some of the historical outcomes that were reported might not actually be as relevant to today because the way we do things has changed quite a lot in the lab.
Yeah, and we're always looking at new ways as well. So there's always something happening in the background with our research team to see how even more gentle we can be with the eggs. If a patient has particularly fragile eggs, we can use our laser machine to sort of assist the needle going into the egg without causing sort of too much force on the shell of the egg. So there's so many different things we can try depending on how the eggs respond. And there's always new things coming along at all times, that we're trialing, and new research that's coming out.
What piece of new research that you've heard of recently has excited you the most?
I think one of the more exciting is using AI to find a sperm that's mobile and moving, and being able to draw our attention to that sperm. So at the moment, when there's a poor sperm case and we put the sample down the microscope, we often have to just scroll around the microscope looking for a sperm until we spot one that's moving. But there is some new AI tools that will search that sample for us on a laptop and put a red box around a sperm that is moving and draw our attention to it. So I think that will help us massively with timing and being able to find that sperm much quicker. It will also be able to potentially know what a good sperm looks like before we can identify it. So there's definitely some exciting tools where it'll be able to help our efficiency, get the sperm injected quicker, but also potentially be smarter than us at being able to identify what a good sperm is as well.
And there's some things that are available in IVF in other countries that we don't use because of ethical and legal reasons. I actually was chatting to someone at a conference recently about an AI tool that can tell a sperm carrying an X from a sperm carrying a Y.
That is interesting.
But sex selection is not allowed in Australia, so we probably won't get that tool here.
No,
But you could technically have a very high chance based on AI sperm selection of choosing a sperm carrying an X chromosome or a Y chromosome, which is how sex is determined.
Yes. Very cool.
I guess in IVF there's many areas where what you can do is different to what people consider or ethical bodies consider of what we should do.
Yeah.
And sometimes the community worries about creating designer babies and that kind of thing.
Yeah.
From a science perspective, how real is that danger?
Not very real. Especially in Australia, we are pretty strict with our ethical guidelines. Realistically, we're not even there yet at being able to select a child with blue eyes or brown hair. Yeah, I don't think we need to worry about that anytime soon, but it'd be interesting to see, where it goes in the future. But I do like that we are quite strict here in Australia and we don't have to really worry about things getting too crazy.
Yeah, we don't experiment on our kids in IVF. Not here.
No, we just want healthy babies.
We just want a healthy baby. And in terms of automation in the lab, there's a lot of talk about that internationally. Where do you see that going?
I think it will be quite helpful, to be honest. Yeah, we've often talked about, when I was at uni, how robots were going to take over our jobs and automation was going to become, the lab. I think as I've sort of been working for the last 10 years, I've realised that it can only really help us. We're only a couple of bodies in the lab, and I think automation will probably create a better environment for the eggs and the sperm and the embryos. It will potentially help us find more eggs in the egg collection, find better sperm. So I think instead of trying to fight it, I think it'll be better to embrace it. And I think ultimately it'll be better for the patients in the long run to be creating the best possible environment for their eggs and sperm and embryos.
When we talk about automation, we're really talking about what is sometimes like taking out some very mindless, repetitive tasks out of the day of the embryologist so that you can spend time doing the important human aspects of work that only a person can do.
Yeah.
Would you say that's fair?
Yes. There's lots of research going into how to automate things, become more efficient. But ultimately we are, wanting to do the best things for the patients. So where we can use automation to speed up those tasks, like the administrative tasks, paperwork, data entry, those sorts of things, we will happily take them so that we can focus heavily on the embryos, the culturing of the eggs, the selection of the sperm, and put our time and attention into that. So there's absolutely a place for it. Lots of research in automation in IVF, but our focus is the development of the embryos, and that's our passion. So, yeah.
Yeah, it's really exciting, I think. It's one of the reasons that I've never lost any passion for assisted reproduction. It's just so interesting, and there's so much scope for continual improvement and better outcomes for our patients.
Yeah, and that's the goal. Like, ultimately, we just want the best possible outcome for a patient and the best pregnancy rates. So, yeah, there's no point trying to fight it. Yeah.
One of the things, Alex, we often talk to our patients about is success rates. And Melbourne IVF as a lab always pride ourselves on aiming for the highest success rates. From the lab perspective, what do success rates mean, and how should we communicate these to our patients?
So the success rates are what we base like most of our training and benchmarks on. But it's really dependent on each different process along the way. So we have success rates right at the beginning from how many eggs are collected for each patient and each scientist, how well your fertilization rates are, how well the embryo development rates are, all the way through to pregnancy and live birth rates. So there is not just one success rate.
So many metrics.
There's so many, and it's really the tool that we use to know how we're performing. And every month we're looking at them to make sure that there hasn't been a dip, or if there's been a spike to know what we've done differently that's caused that. So it's something that we're constantly looking at. But there's so many different factors as well that can affect a success rate. So outside of the lab, the patients themselves have so many different reasons for why they might have a 30% chance and another patient might have a 10% chance. I'm sure you speak to your patients a lot about those sort of chances, but there's so many different reasons. So it's often a lot of counselling that kind of goes into telling a patient their chances of an embryo implanting. But there's a lot out of our control as well, unfortunately.
And why might a good-looking embryo fail to implant?
There's a couple of different reasons. If the embryo hasn't been genetically tested, we don't know the chromosomal status of that embryo, so it could look really nice on the outside. But ultimately, if it's aneuploid, there's a very high chance that it won't implant. So that's one reason. The endometrium could be a reason, but I'm sure you know more about that. And the other unfortunate side of it is just chance as well. You could have a really nice embryo, but it doesn't mean it's going to have 100% pregnancy rate.
Yeah, I sometimes talk to patients about the embryo needing to do the right thing. It's got the right ingredients sometimes, but it also has to put those pieces of the puzzle together and orchestrate all of the moves needed to make a perfect human, and they don't always do everything right.
Yeah.
It's frustrating as anything to
Yeah.
patients because they feel like they've done everything they can.
Yeah.
And sometimes, unfortunately, your doctor's done everything they can, your scientist's done everything they can, your nurses have done everything they can, you've done everything you can, and a great-looking embryo still doesn't always work.
Yeah.
Yeah, it's very upsetting.
Yeah. But sometimes it just takes a couple of those goes to get there.
Yeah.
So
Absolutely.
yeah, it's not the end of the road, I guess, when it doesn't work.
Yeah, perseverance is key.
Yes.
Terrific. Well, thank you so much,
Thank
Alex, for
you.
coming on Knocked Up. It's been a pleasure to have you.
Thanks for having me.
And hopefully you'll join us again in the future.
Love to. Thank you.
Thank you, Alex, for taking us behind the scenes of the lab and helping us understand the science and the care that goes into every embryo. This episode of Knocked Up is sponsored by Women's Health Melbourne. Your reproductive health deserves specialist care. Women's Health Melbourne provides expert fertility assessment, endometriosis management, and personalised preconception guidance led by Dr. Raelia Lew. If you're ready to understand your body and make informed decisions, book your appointment at womenshealthmelbourne.com.au. If you're navigating your own fertility journey, you'll find more resources in the show notes. And if you're enjoying Knocked Up, hit follow on Apple or Spotify, and thank you to everyone for leaving a 5-star review. It truly helps us grow.